Good morning, everybody. It's a privilege to address you at this first Medical Council conference on safety and safety in healthcare. It's not the only conference that has occurred this autumn. The State Claims Agency had a really effective, enlightening conference some weeks ago, and there's a national conference hosted by the Department of Health in another couple of weeks. But before I start, I thought I would ask the audience some questions in relation to safety. I'd just like people to put their hands up who travelled by public transport this morning. How many, you can put them down, how many of you expect that the train service or bus service inspected their buses and rail tracks for safety this morning? Okay, very few. Those of you that didn't put your hands up that travelled by car, how many travelled by car? Okay. How many of you tested your tyres in the last week? Okay, about 3%. So it seems to me that there's an assumption that institutions and individuals are safe and practice safety, when in reality you don't have a culture of safety from the time you wake in the morning to the time you sleep. I believe the philosophy of safety and managing risk is something that needs to be taught, and it's a statement and a practice that you have to use for whatever you do in life, be it complex heart surgery, pilot space shuttles, or primary care physician. Healthcare, as we know in Ireland today, is in a very challenging position. It has the highest medical litigation in the world, higher than the United States and the state of Florida. But medical litigation, and there's some approximately 180 million paid out each year now, euros, in settlements in relation to harm as a consequence of medical care. Now, the general perception is that when somebody dies at the moment, that is due to medical failure, when in fact death itself is an inevitable consequence of being born. It is part of life. If we look at the cars that drive around, most cars are 10 years old or less. But if you look at us here in the audience, many of us are in our 60s and 70s. And indeed, the life expectancy in Ireland now is in the late 70s, early 80s. If we drew the analogy with cars, we'd all be on the scrap heap. We've only achieved this lifestyle and age, by looking after ourselves, but also by the sophisticated healthcare that can now be provided. And as a consequence, the expectation of society is huge in that life should continue beyond 80 years of age, or even to 90 years of age, with all our faculties and with all our capabilities. And if anything happens to us, it's considered a medical failure. When we look at problems for surgery, which I know a little bit about, Atul Gawande estimates that there are 3 times more surgical deaths in the United States as compared to road traffic accident deaths. In Ireland, that would be somewhere around 500 to 550 deaths a year from patients undergoing major surgery. If a quarter of that number could be reduced by managing near misses and near calls or learning from failure, then that would in fact provide huge extra resources. Resources, as we heard some weeks ago, particularly in intensive care, are particularly limited. So having a patient safe, having a culture of looking at near misses and failures, knowing how much we do, how well we do it, and what we do, and using that information to continually assess and look at team improvement. all too often, individual doctors are blamed for the particular failure. We will see many times that after investigations that it's stated that systems fail. It's not actually systems that fail, it's teamwork that fails. So we have to learn to, first of all, accept that failures occur all the time and near misses occur all the time, that they're not bad things, they're actually something that we must learn from. If you will hear later on, we're very privileged today to have Colonel Eileen Collins, the First Lady pilot and First Lady commander of the Space Shuttle program here, and she will tell you about near calls, near misses, and disasters, and the learning, the intense learning that came from that to improve the consistency and safety of the program. I can certainly tell you personally from my experience in pursuing the correction of infant and neonatal complex heart problems 30 years ago, the failures that we had in treating these children that without surgery would certainly die, but with surgery carried a mortality of 30% or more. The failure had to be treated not just as a failure in a grieving process, it had to be treated as an intense learning process for everybody in order to, that the next time you went to do that operation with your team, your senior nursing staff and consultants, that we had learned something additional that the next case would be successful. And at the same time, psychologically, we had to learn techniques to support one another, but also to support the bereaved family and grandparents and so on. So the failures that happen in medicine, like in aviation, are hugely important to making our healthcare more consistent. And it is essentially really not based on a single individual, but that individuals from many different specialties such as cardiac surgery, intensive care, pharmacy, operating room nurse, post-op care nurse, physiotherapist, all work cohesively together like we see some of our rugby teams working now at the European rugby or international rugby, where a squad, not just a team, but a squad where players come on and off the field. Likewise with surgery, complex and complicated surgery, different players from different specialties all come in and support one another. But the essence of that kind of teamwork requires briefing and debriefing, and as well as using protocols and checklists, but creating an environment in particular where even the youngest and newest within the team structure is encouraged to speak up without fear of being denigrated. All too often in our society, certainly in my profession, it's all too easy for a senior or somebody else to denigrate and harass and bully those younger members who are doing all the foot soldier work and who are most likely and most unconflicted to detect the actual mistake that's been made, whether it's in a drug prescription or whether it's in a chemotherapy, cancer treatment dose, or whether it's in open heart surgery. I well remember 36 years ago when I was training a little baby of 2 kilos that my senior staff man and I were doing a shunt on. Normally we give heparin to anticoagulate the baby. We could not understand why the graft was bleeding excessively. This baby was about 2 kilos, just newborn and blue. After 2 hours in the operating theatre, we were eventually told that one of the assistant colleagues at the other side of the table had given 10 times the dose of heparin. And as a consequence, the baby was totally anticoagulated. We ended up resolving the problem. The baby's blood volume was replaced 5 times, but that little baby eventually died 28 days later, all because of that one incident. So that kind of error and management, it still happens today. When we look certainly at complex and complicated surgery, these kind of simple problems do happen, and we have to create a teamwork environment, A, to detect them, and B, to resolve them, without blaming anybody in particular or holding anybody's career back. There has to be a learning process. So the purpose of this conference really is just to highlight a safety culture in everybody's life and practice, and as we're all healthcare providers, in particular healthcare, at institutional level, from board, CEO, right at senior leaders, consultants really are the providers and managers of the complex health care delivery that we as a profession now deliver in this century. They have a key role to play in their leadership, in their practice, and what they do. So the fundamental part of this conference is just to start to create an openness and transparency about safety, and to adopt it in a very open fashion.